Yes, madam.
Okay. So, Honorable Chairperson, distinguished panelists, moderator, and respected audience. Assalamu alaikum and a very good morning. It's my honor to have this opportunity to talk on echocardiographic evaluation of the cardiomyopathies. Actually, cardiomyopathy is a very vast subject. So to cover this topic within 5 minutes to 1 hour is really advice that I will try to make it simple and only focus on the important echocardiographic aspects of different types of cardiomyopathy. So what is a systolic and diastolic dysfunction? It represents a heterogeneous group of diseases that often leads to progressive heart failure with significant morbidity and mortality. It may be classified into primary cardiomyopathy, that is primary diseases intrinsic to cardiac muscle, dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, ERVC, that is arrhythmogenic right ventricular cardiomyopathy, non-compaction cardiomyopathy, and Takotsubo cardiomyopathy. There is some systemic disease or secondary condition which may process leading to myocardial dysfunction and produces feature like cardiomyopathy, like feature of dilated cardiomyopathy, infiltrative cardiomyopathy, and restrictive cardiomyopathy. So, approach to patient with cardiomyopathy, like any patient, first there should be history taking, clinical examination, and ECG and X-ray chest. So the echocardiologist should have a background of the patient, and then he or she should proceed for echocardiography. And echocardiography is most of the cases is diagnostic. So, diagnosis of the primary cardiomyopathy, it established possible etiology of secondary cardiomyopathies, whether it is due to ischemia, valvular, or congenital heart disease, or to assess the severity of the disease. To assess the severity, ventricular volume should be calculated, ejection fraction should be calculated, hemodynamic status should be evaluated, and also the complications should be focused, whether there is any MR, any thrombus, and to assess the prognosis of the disease process, systolic function as well as diastolic function, especially filling pressure, should be evaluated by echocardiography. So now I will give an overview of dilated cardiomyopathy. Dilated cardiomyopathy is characterized by global decrease in myocardial systolic function with dilatation of the ventricle. Actually, the LV dilatation with reduced global LV systolic function is the hallmark of DCM. And there are some primary and secondary abnormalities which may run parallel in case of DCM. The left ventricle dilatation, there is increasing sphericity of the LV geometry. I will explain it shortly. There is apical and lateral displacement of the papillary muscle, resulting functional mitral regurgitation. There may be, due to reduced EF, there may be stasis of blood flow, and which may give rise to the thrombus formation. There may be left atrial dilatation due to diastolic dysfunction, and as a result of LA dilatation, there may be atrial fibrillation, LA thrombosis, pulmonary hypertension, tricuspid regurgitation, or secondary abnormalities in case of DCM. Right ventricular dilatation dysfunction may be primary or secondary, and when it's associated with DCM, it carries a worse prognosis. So what are the 2D echocardiographic findings in case of DCM? Is increased LV internal diastolic dimension, systolic dimension, increased EDV, and increased end systolic volume. Left ventricular dilatation is spherical. What happens? The gradual dilatation more along the short axis of the LV. So it causes a reduction of the ratio of the long axis diameter to short axis diameter, and it decreases less than 1.5. Normally it is 1.6:1. There is increase in LV mass. Wall thickness may be vary, but most of the cases it is within normal limit. There is a decrease in all variables of systolic function. Sometimes fourth chamber cardiac enlargement is present. So here is an example of our long axis view in a patient of DCM. We can see the dilated LV and reduced contraction of the anteroseptum and the infralateral wall. Here, short axis view at the level of mitral valve, we can see the dilated LV and global hypokinesia. So LV systolic function is severely reduced. At the fourth chamber, apical fourth chamber view, we can see the dilated LV with reduced global systolic function, as well as there is dilated left atrium. So for volume estimation, ASC recommended biplane measurement of volume. If we have 3D volume calculation is more accurate, linear measurement of volume calculation is no longer recommended. In case of DCM, LV volume indices increase and EF decrease. LV end-diastolic volume index may increase even up to 100 milliliter per meter square. And with the increase of end-systolic volume index, the prognosis worsens. So with increase of end-systolic volume index, more than 25 milliliter per meter increase, there is a risk of an adverse outcome which increases sharply. And LV ejection fraction decrease less than 40%. More the reduction in LVF, it carries the worst prognosis. So what the finding of M mode? There is increased E point septum separation. We can see that from the early E wave, the septum, this distance is increased, and there is excursion of the mitral leaflet to increase LV EDP. M mode of echocardiogram of protein valve show that it reduced cusp separation. Here we can see the normal cusp separation. So in case of DCM, there is aortic cusp separation is reduced, and the curve closer. We can see the curve closer at the end. It indicates that there is progressive diminished forward flow. So DCM may be associated with normal RV or dilated RV. Normal RV is associated with good outcome, but at the bottom, we can see that the RV is dilated and TAPC is reduced. So this dilated LV with reduced RV systolic function carries a worse prognosis in case of dilated cardiomyopathy. Left atrium assessment, biplane volume assessment is recommended. So LA volume index may increase even up to 50 milliliter per meter square, and minimal actual volume at end diastole is more predictive of outcome than maximal LA volume at end systole. For Doppler echocardiography, forward flow assessment by LVOT time velocity integral, volume-based stroke volume calculation, and cardiac output calculation. All these parameters are usually reduced in case of DCM. Diastolic properties assessment by mitral inflow pattern, pulmonary vein flow, and annular Doppler tissue imaging. At the early stage, there may be relaxation abnormality, but as the disease progresses, there is severity of diastolic dysfunction. Diastolic properties of RV are not routinely used for day-to-day practice, so I will not go into detail of it. So here we can see that at the earliest there is relaxation abnormality, the DT is prolonged, but as disease progresses, there is a safety pattern, E wave become tall and A wave is very short. This short E wave indicates that there is reduced LA systolic function due to poorly compliant LV. So mitral regurgitation is the constant feature of DCM. What is the pathophysiology of MR? MR in DCM is usually due to abnormal leaflet tethering resulting by the change in ventricular shape from ellipsoid to spherical, or due to, we can say that there is the annulus dilated. So due to annular dilatation, it causes the non-coaptation of the leaflets and results in MR. Strain imaging in DCM, that is a GLS, a sensitive measure of LV contractility and an independent predictor of all-cause mortality in patients with systolic heart failure due to DCM. Here we can see that the strain, global longitudinal strain, use in all segments of LV. This is a condition we must distinguish from whether it is due to idiopathic dilated cardiomyopathy or valvular cardiomyopathy with LV dysfunction, especially if there is DCM with MR or severe MR with DCM. To focus on it, we should carefully watch the mitral valve morphology, whether there is any leaflet thickening, whether there is any prolapse of leaflet, or there is any history of long-standing pansystolic murmur. It will differentiate organic MR from functional MR from DCM. And ischemic cardiomyopathy, the DCM closely mimic ischemic cardiomyopathy, but there is certain subtlety. But in case of ICM, there is regional wall motion abnormality with different degree of severity. In case of DCM patchy involvement, the Regional wall motion abnormality don't conform to arterial distribution, but regional wall motion abnormality conform to coronary perfusion territory in case of ICM. Dyskinetic areas and aneurysm are not seen in case of DCM, but these are the characteristic feature in case of ischemic cardiomyopathy. So here is an example of ischemic cardiomyopathy. We can see that the severely reduced systolic thickening of anteroseptum, and here we can see the distal anteroseptum is almost akinetic, and short axis view we can see that this anteroseptum is akinetic, and there is hypokinetic infralateral and the lateral wall. Here we can clearly see the anteroseptal akinesia and the rest of this severely hypokinetic. Septum and apex is akinetic, and lateral, basal and mid portion is hypokinetic. Here inferior is akinetic, basal and mid anterior is hypokinetic, and apical anterior is akinetic. So there is different degree of regional wall motion abnormality in this patient. But we have to remember that with the presence of different degree of regional wall motion abnormality, we cannot definitely diagnose a case of ischemic cardiomyopathy. To confirm ischemic cardiomyopathy, we should have the CAG, coronary angiogram, evidence of coronary artery disease, or prior evidence of OMI in ECG. With the absence of this finding, we cannot write it is a case of ischemic cardiomyopathy. We can write in our echo report it is a case of dilated cardiomyopathy, and the possible causes may be ischemia. So here is an example of apical aneurysm in case of ischemic cardiomyopathy, and in the bottom we can see the thrombus in the aneurysmal apex. So there is some Doppler, echo and Doppler predictors of adverse prognosis in dilated cardiomyopathy, like increased LV diastolic volume and systolic volume, reduced ejection fraction, and reduced sphericity index. Among the diastolic properties of the LV, restrictive mitral inflow pattern, pseudonormal mitral inflow pattern, elevated E by E, that is more than 15, and left atrial dilatation carries worse prognosis. Now I will give a brief overview of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a genetic disorder. Echo diagnosis of HCM is based on finding of an unexplained hypertrophy, that is hypertrophied LV without the common causes like hypertension, aortic stenosis. This cause will be absent, and we will find the hypertrophied LV. And AHA and ESI guideline recommend that when the wall thickness is equal to more than 15 millimeter, it may be considered as a criteria of ACM. Distribution of LV hypertrophy is variable. There may be septal hypertrophy with or without LV obstruction. There may be symmetric or concentric hypertrophy. There may be apical hypertrophy, hypertrophy of the LV free wall, or there may be right ventricular hypertrophy. So what are the M-mode and 2D echo findings in case of HCM? Asymmetric septal hypertrophy. Thickening is confined to the base and impinges on the LVOT. There may be symmetric ventricular hypertrophy, apical hypertrophy, LV cavity appears small, and presence of systolic anterior motion, especially in case of hypertrophic obstructive cardiomyopathy. Here, parasternal long axis and the short axis view showing that we can easily see that how much the anteroseptal wall is hypertrophied. So the ratio between this anteroseptum and the infralateral wall is more than 1.5. Here, short axis also show that the septum and anteroseptum and posterior septum is markedly hypertrophied. So here is a vicinal view showing that the marked hypertrophy of the anteroseptum, asymmetric anteroseptal hypertrophy. If we carefully watch, we can see that there is some speckle appearance. It indicates the intramyocardial fibrosis, typical of HCM. Here, fourth chamber view, we can see the marked septal hypertrophy, and we can see clearly that within the septum there is a high echogenicity. There's some speckle appearance. It indicates the intramyocardial dysuria or fibrosis, characteristic of hypertrophic cardiomyopathy. Here, a parasternal long axis view showing symmetric hypertrophy in a case of HCM. Apical hypertrophy, apical HCM is difficult to diagnose, and 15% of the cases it may be with 2D. So contrast help in the diagnosis. We can see with contrast there is only this portion of the cavity is visible and the marked hypertrophy is evident. So contrast echo help in the diagnosis of apical HCM. What is systolic anterior motion of mitral leaflet in case of HCM? It is the abnormal anterior motion of mitral leaflet into the LVT during systole. There may be anterior leaflet or posterior leaflet, or both leaflet can move into the LVOT and causes dynamic LVOT obstruction. For dynamic LVOT obstruction, it requires narrow LVOT, there's hypercontractile LV, and redundant mitral valve deflects. Severity of LV obstruction is related to the duration and degree of SAM and to the reduction in LVOT size. It causes the reduction in stroke volume, and it raises the ventricular pressure, creating more hypertrophy. So here is an parasternal longus view showing the systolic anterior motion of mitral leaflet. We can see that during systole, the AML moves towards the septum and it causes the LVOT obstruction. Here in mode view, it does so that AML moves forward. This is a normal, but in systole it should come down. But we see that here again the anterior mitral leaflet moves forward and approaches to the septum, causing LVOT obstruction. Here apical longus view showing the systolic anterior motion of the anterior mitral leaflet, causing LVOT obstruction. So Doppler is the most practical means to assess the hemodynamics of hypertrophic cardiomyopathy. Hemodynamics are critical to symptom development and disease classification. LVOT obstruction, pulmonary pulse wave Doppler from apical echo window show increased flow velocity across LVOT, and continuous wave Doppler assess the degree of LVOT obstruction. Here we show that when you place the pulse wave Doppler sample volume just across LVOT, it indicates there is increased flow but cannot measure the gradient. But by placing the continuous wave Doppler across the LVOT, we can measure the actual peak velocity and gradient of LVOT. So about 20 to 25% of patients having a resting LV gradient about 30 mm of mercury. When resting gradient is more than 50 mm mercury, no provocative maneuver is needed. If gradient less than 50 mm, Valsalva maneuver is performed. If the gradient is less than 50, provocating testing to elicit dynamic LVOT obstruction. LVOT obstruction is in HCM is dynamic, and it depends on loading condition and contractility. Here we can see that the resting gradient and after Valsalva, it was not so much increase, but after amyl nitrate inhalation, the gradient increased. So it indicates a dynamic LVOT obstruction after provocative test. Doppler spectral pattern in LVOT obstruction is really late peaking in envelope, and it is dagger shape. It differentiates from MR that MR is early peaking of longer duration, and MR peak velocity and systolic blood pressure may help to assess the LVOT gradient, and also it can help to verify the LVOT gradient. So LVOT obstruction in HCM is most common in case of females, elderly, greater degree with hypertrophy, and it independently predicts more severe diastolic dysfunction and symptoms. It also predictive of stroke, atrial fibrillation, and arrhythmia-related sudden cardiac death. So there may be mid-cavity obstruction, and mid-cavity obstruction is steep, dagger-shaped, Doppler involved with latest peak and very short duration. We can see that the mid-cavity obstruction is of short duration. So mitral regurgitation in HCM is due to systolic anterior motion of the anterior mitral leaflet, and it always directed posteriorly. It is like bell-shaped and is early peak with longer duration. And we can see that the LVOT obstruction is dagger shape, but this is bell-shaped. So by the shape, by its duration, and by early peaking, we can differentiate mitral regurgitation from LVOT obstruction. Here is an apical 5-chamber view showing that the turbulent flow in the LVOT. So it is a LVOT obstruction, a posteriorly directed mitral emergent. Here, steel frame showing the LVOT obstruction and a posteriorly directed emergent. So what is the role of the stent imaging in HCM? It has a characteristic pattern. Longitudinal stent is mostly reduced in the thickest myocardial segment. Stent imaging measures global and regional function and can detect reduced myocardial function. Here on the top, we see that there is anteroseptal hypertrophy is more pronounced in these cases, and there is corresponding reduction in the stent in the anteroseptal area. Here on the left and the bottom, the apical HCM is evidenced by contrast echocardiography, and by stent imaging, we can see that only the apical stent is reduced. There is some selection criteria for management strategy of patient with hypertrophic obstructive cardiomyopathy. So when a patient with maximum LV wall thickness less than 18 millimeter, the LV hypertrophy is confined to the base of the septum. There is no mitral valve abnormality, there is no papillary muscle abnormality, and there is a suitable septal branch. This patient should be considered as a case of alcohol septal ablation. But with more hypertrophy, that is septal hypertrophy more than 18 millimeter, with the hypertrophy involve much of the septum and other areas like basal, mid-ventricular, apical, and right ventricular, and there is mitral valve abnormality, there is papillary muscle abnormality, this patient should be selected for septal myectomy. So that is surgical septal myectomy, and usually surgical septal myectomy is the ideal for hypertrophic obstructive cardiomyopathy. What is NSHCM? Presence of inappropriate LV hypertrophy with mildly dilated cavity and LV systolic dysfunction. But it should be documented by previous clinical and echo evidence of HCM to confirm the diagnosis. Due to reduced LV contractility, SAM and dynamic LV obstruction not present in case of end-stage HCM. Advanced cases, restrictive diastolic dysfunction is commonly present. So current recommendation for screening of first degree relative for patient with HCM, that annual screening with echo until the age of 18 and every 3 to 5 years indefinitely after the age of 18. So there, after intense training and for very much active athletes, there may be LV hypertrophy. And how to differentiate it from this LV hypertrophy in case athletes from HCM? There is some characteristic. That is, in case of athletes, hypertrophy is more symmetric. LV wall thickness is rarely exceed more than 70 millimeter. Indeed, it is 13 to 50 millimeter only in case of highly trained male athletes. The LV cavity dimension is increased in athletes' heart. Diastolic function is normal. Strain imaging finding are normal. LV size is normal or minimally dilated, and marked resting systolic anterior motion usually not present in case of athlete's heart. Now I will give a review of overview of restrictive cardiomyopathy. So primary restrictive cardiomyopathy characterized by restrictive ventricular filling due to idiopathic myocardial abnormality. Increase in LV wall thickness is due to infiltrative disease like amyloidosis. Systolic function usually normal in the early stage, but may reduce in the later stage of the disease. This entity is a subset of heart failure with preserved ejection fraction. So what are the 2D echo features in restrictive cardiomyopathy? The ventricular size may be normal. There may be relatively preserved global LV systolic function. Biaxial enlargement is the marked feature of RCM, and this is as a consequence of poor ventricular compliance. There is increased wall thickness due to infiltration of the material. So the Doppler features the characteristic of restrictive cardiomyopathy. Either mitral or tricuspid inflow, it reveals the restrictive pattern, that is increased E velocity, decreased A velocity, increased E by A ratio, shortened DT, and decreased IVRT. Pulmonary hepatic venous flow reveals that there is decreased systolic velocity compared to diastolic velocity. There is increased axial flow velocity reversal and duration in the pulmonary vein. There is increased diastolic flow reversal in the hepatic vein during inspiration. Tissue Doppler imaging of septal mitral annulus reveals that there is decreased systolic velocity as well as decreased early diastolic velocity. So the inherent stiffness and fibrosis of RCM is well seen in strain imaging with reduced GLS in the basal segment, which progresses to the mid and apical segment. And all these findings are summarized in this figure. By 2D, we can see the increased wall thickness in the LV, and there is biaxial enlargement. Mitral inflow reveals there is restrictive pattern, tall E, short A wave, and annular tissue Doppler annular imaging reveals there is decreased systolic as well as early diastolic velocity. Pulmonary venous flow interrogation by pulse wave Doppler show that there is decreased systolic flow and increased diastolic flow. Hepatic venous flow, there is indicate that the diastolic reversal mainly in inspiration, and strain imaging, we can see that strain is mostly reduced in the basal, followed by the mid segment, and apical strain is relatively preserved. That is, apical sparing is the characteristic of restrictive cardiomyopathy. So amyloid cardiomyopathy are usually present as a form of restrictive cardiomyopathy. What is the echo feature? There is diastolic dysfunction, which is the commonest and earliest feature. There is symmetrical LV wall thickening, typically involving the IVS, and it may confuse with HCM. But a granular speckle appearance of the myocardium due to collagen or amniotic dysfunction, that sometimes there may be disproportionate RV enlargement, and pericardial effusion is present about 1/3 of the cases. Here we can see that the typical feature of amyloid cardiomyopathy, the wall antiseptum and infralateral was thickened, and we can see the bright, shiny appearance, the granular appearance. As I have shown the HCM, we see in that cases there was the speckle appearance, but it is a bright and shiny appearance, and there is a pericardial effusion, minimal pericardial effusion posterior to LV posterior wall. Here on the left, the 2D echo feature, we can see the granular thickened myocardium, and there is effusion and then posterior to the LV posterior wall, and also superior to the RA. The apical fourth chamber and subcostal fourth chamber show there is biatrial enlargement. And here tissue Doppler imaging showed systolic velocity as well as the annular diastolic velocity is reduced, and systolic strain imaging showed that the mostly reduced strain is in the basal and mid segment, and apical strain is relatively preserved. Now come to arrhythmogenic right ventricular cardiomyopathy or arrhythmogenic right ventricular dysplasia. It caused by progressive replacement of RV myocardium by fibrous fatty tissue. Familial occurrence is usually 30 to 50% cases. It may be autosomal dominant or autosomal recessive, male, female predominant. Lethal edema is the presenting feature in young patients. ECG has characteristic wave, and clinical sign of RV failure, LV dysfunction, and VT are poor prognostic factors. So for echo diagnosis of ARVC, there is a major criteria and minor criteria. A definitive diagnosis includes 2 major and 1 major and 2 minor criteria. A borderline diagnosis with 1 major, 1 minor, or 3 minor criteria. A possible diagnosis need 1 major or 2 minor criteria. So what are the major criteria? Regional RV akinesia, dyskinesia, or aneurysm with RVOT dilatation in parasternal longus view. It should be more than 32 millimeter mercury, or in parasternal short axis view, RVOT dimension should be more than 36 millimeter. And fractional area change equal to less than 30, but without aneurysm, and either the RVT dimension increase in parasternal longus view, it range between 29 to 32 millimeter, and in parasternal short axis view, RVT dimension range between 32 to 36 millimeter, and fractional area change usually range in between 33 to less than 40%. So besides the major and minor criteria, there are other echo findings in case of ARVC. There may is systolic RV systolic dysfunction, RV regional wall motion abnormality, typically apical and anterior. Morphological RV abnormalities include trabecular derangement, moderated by hyperreflectivity, focal RV circulation. RV systolic pressure is usually low, and contrast echo is useful in delineating RV morphology and contractility. Parental echo findings in case of patient with ARVC, RV focus view, we can see the apical RV aneurysm, and there is marked trabeculation. In subcostal view, we can see the focal aneurysm of the RV, and parasternal longus view, there is RVOT dilatation. Short axis view also indicates the RVOT dilatation. There is a case of a 22-year male ballet dancer who presented with syncom, and when the RV was evaluated, we can see that compared with normal subject, this RV is dilated. There is high echogenic from mid to apical RV free wall. So this RV, there must be RV akinesia, the free wall and the apex, and there is increased trabeculation. Here, three different view of the same patient focusing RV. We can see the increased trabeculation and apical high echogenicity with thinning. So this apex must be akinetic. There is aneurysmal RV apex with high degree of trabeculation. And here the hyperreflective of the moderator band and a part of the apical aneurysm is visible here. So these features suggest that this patient may have ARVC. So there is some echo criteria to predict worst prognosis in case of ARVC. RV fractional area change less than 23%, TAPC less than 70 millimeter, and when ARVC is associated with the RA dilatation, then right axial short axis diameter and BSA ratio, if it exceeds more than 25 millimeter per meter square, at baseline it indicates that there is a worst prognosis or it carries a worst prognosis in case of ARVC. So, what is a non-compaction cardiomyopathy? The non-compaction cardiomyopathy results from an embryonic arrest of myocardial compaction. There is extensive spongy transformation of the myocardium, coarse trabeculation and deep recesses covered with endocardium, intratrabecular spaces filled by direct blood from the LV cavity. There is segmental thickening of the LV wall consists of two layers, a compacted epicardial layer, a thickened endocardial non-compacted layer. End-systolic ratio of non-compacted to compacted layer is more than 2. Predominant areas of the trabeculation of LV non-compaction is usually mid-lateral, mid-inferior, and apical segments. LV non-compaction often presents in the fourth decade of life with enlarged LV and reduced LV ejection fraction. Clinical feature, there is congestive heart failure, thromboembolic events, ventricular tachycardia, and it may give rise to the sudden death. So on the left, we can see the industrial view from the mid to apical lateral, there is trabeculation. And on the right, there's the ancestral view. We can see the prominent trabeculation and the recesses, and the ratio of this non-compacted to compacted myocardium is 3. So this is a feature of LV non-compaction. Here, apical short axis view, we can see the marked trabeculation and recesses, and this non-compacted area to compacted area ratio is more than 2. So this is a case of non-compaction cardiomyopathy. Finally, the Takotsubo cardiomyopathy. What is Takotsubo cardiomyopathy? It is also known as apical ballooning syndrome. In the setting of acute chest pain after physical or emotional stress, there is transient hypokinesia, akinesia, or dyskinesia of the LV, include from mid to distal LV, with or without apical involvement. There is hypocontractile apical segment involving more than one coronary territory with hypercontractile basal segment. Takotsubo may affect both LV and RV, and to confirm Takotsubo, there must be absence of obstructive coronary disease or angiographic evidence of acute plaque rupture. New ECG abnormality may present either ST segment elevation or T-vein inversion or modest elevation of cardiac troponin. There should be absence of other causes which may cause a transient hypokinesia, and increased catecholamine play a major role. Almost all of these cases recover fully. Here is an example of Takotsubo cardiomyopathy in the parasternal long view. We can see the distal anteroseptal, mid to distal anteroseptal akinesia and distal infralateral akinesia. Here, apical fourth chamber view, we can see that from the mid to apex is akinetic, and it gives the formation of apical ballooning. So it is known as the apical ballooning syndrome. Now the comparison of the different echo parameters among the different form of primary cardiomyopathy. When you compare the LV industrial dimension, it is increase in case of DCM and decrease in case of HCM and some cases of non-compaction cardiomyopathy, and remains normal in case of RCM and ARVC. Atrial size increase in HCM, DCM, and restrictive cardiomyopathy remains normal in ARVC, normal to decrease in case of non-compaction. LV wall thickness increase in HCM and restrictive cardiomyopathy, and when there is focal non-compaction, in that area LV wall thickness increase, but remains normal in ARVC and most of the cases of DCM. LV ejection fraction is markedly reduced in case of dilated cardiomyopathy because it is the hallmark of DCM. It may be normal and increase in case of HCM, normal in case of ARVC, and decrease, I have already mentioned, in case of DCM. RV function should be decreased, and it is the obligatory finding of ERVC, and it may be normal in case of HCM, normal to decrease in dilated cardiomyopathy, decrease normal or decrease in case of non-compaction. So these are the comparison of the different types of primary cardiomyopathy. I will not go detail into the secondary cardiomyopathy, but I want to share with you two interesting cases to point out and to focus how much echocardiography is important, and while doing echocardiography, how much the suspicion is needed to find out the cause of secondary cardiomyopathy. So here is an example of a baby who presented with shortness of breath, and parasternal longest view showed there is a dilated LV and mitral regurgitation. We see, if we carefully monitor, we can see that in the mid-anterseptum there is subendocardial echogenicity. Short axis view. Short axis view, due to tachycardia of the baby, it assumes that the LV function is not so decreased, but if we notice carefully that this is the tendon, this is not the endocardium, but here is the anterseptum and there is severely reduced systolic thickening. So we approach the apical fourth chamber view, the anatomical view, and we can see the dilated LV and the reduced LV systolic function. Then we have suspicion in mind, and we focus on the papillary muscle. We find that the papillary muscle is echogenic. So with our suspicion, we look for the origin of the coronary artery. And here you can see at the level of the great vessel, this is the aorta. Artery, the left coronary artery is the hallmark of the it is anomalous left coronary artery origin from the pulmonary artery. Primary idiopathic cardiomyopathy. Another case, another young patient presented with dilatation and LV dilatation. Short axis view, we see that hugely dilated LV with reduced systolic function. Apical fourth chamber view, we see the hugely dilated LV with reduced systolic function. Then after scanning through the parasternal and apical view, we proceed to subcostal view. And as our routine practice, we place the pulse wave Doppler in the abdominal aorta, and we see the sawtooth appearance or low velocity collateral flow. In other words, there is a ductal pattern in abdominal aorta indicate there is a blinded systolic velocity with delayed systolic upstroke and continuous diastolic runoff. That is, it indicates the presence of coarctation. And with this suspicion, we proceed to suprasternal longest view, and we can see that the very nicely that there is a shelf-like position in the descending thoracic aorta, causing marked narrowing of the descending thoracic aorta. Color flow reveals that high turbulence in the descending thoracic aorta. And when you place the continuous wave Doppler sample across the cortex segment, we find that the peak velocity is increased. Peak velocity is about 4 meters per second, and peak gradient is about 64 millimeter mercury. So in this PP, the cause of dilated LV with severely reduced LV systolic function is due to severe coarctation of aorta. It is not a case of idiopathic dilated cardiomyopathy. So, dear fellows, during echocardiography, we should take the history first, do the clinical examination. We should have a high degree of suspicion and do the precise echocardiography to find out the actual cause of the this process. So with this to end the session. Thank you.
Thank you, madam, for your brilliant presentation. This was very, very rich in contents as well as the explanations, full of explanations. I think all the audience have enjoyed the presentation much. Before going to the second presentation, I think we may have some questions and comments.
May I have a question, Dr. Monwar?
Yes, sir. Yes, sir. Yes, sir.
I picked a question from the box, question answer box. That is the
Yes.
how to differentiate between the Takotsubo cardiomyopathy and the apical and LV apical aneurysm. Because the Takotsubo cardiomyopathy is a very common occurrence, not a very common, but a common occurrence in these days of the COVID era, both in the COVID patients and the non-COVID patients. There are studies that the Takotsubo incidence of the Takotsubo cardiomyopathy has been increased, both in the COVID-19 patient as well as the non-COVID patients. There is increased number of the Takotsubo cardiomyopathy. And the question was how to differentiate it from the apical LV apical aneurysm.
Okay, it is difficult, but here you see this. There's in case of Takotsubo cardiomyopathy, there is also chest pain. So, but ECG evidence there will be ST elevation is common, but to definitely differentiate these two conditions, we need the angiogram. If there is a ST elevation, then there is absence of coronary artery obstruction, then it will indicate that this is not a acute AMI. So it is not a case of ischemic heart disease.
স্যার আমি কি একটু সাপ্লিমেন্ট করতে পারি? স্যার আমি কি একটু সাপ্লিমেন্ট করতে পারি?
Sure, sure.
তুহিন ম্যাডাম সুন্দরভাবে সবকিছু বলেছেন। আমি একটা
cardiomyopathy occurs after some stress. But to differentiate, we need the angiogram. Unless angiogram not prove it that is either with coronary artery disease.
স্যার ওই স্টেমিতে আমরা সাধারণত আমরা একটা করোনারি আর্টারি এরিয়া ডিস্ট্রিবিউশন দেখতে পারি, কিন্তু ট্যাকোসুবো কার্ডিওমায়োপ্যাথিতে সেই রিজিওনাল ডিস্ট্রিবিউশন অফ করোনারি আর্টারিটা থাকে না। অন্তত মিড থেকে শুরু করে ডিস্টাল এপিক্যাল ওই সাইডটা টোটাল গ্লোবাল একটা হাইপোকাইনেসিয়া ডেভেলপ করে। সো ইট নট ফলো দ্য রিজিওনাল ইনভলভমেন্ট অফ দ্য পার্টিকুলার করোনারি আর্টারি. This is one point. Another thing is Takotsubo cardiomyopathy not only involved only the apical segment, it also even involved the basal segment, sparing the apical segment, which is known as reverse Takotsubo cardiomyopathy. And even in rarely, it can only involve the mid segment, sparing the apical and basal segment also. So these three things we can take in our mind when you diagnose the Takotsubo cardiomyopathy.
I think
স্যার একটু যদি বলি স্যার বলবো স্যার
I think Dr. Momen is going to add something. Yes.
But yes sir, you rightly pointed out that in this COVID era there is so much stress in the patient, and patient may present with Takotsubo cardiomyopathy, and there are several case reports. So the most striking feature, it is reversible, and there is no thinning, and there is no echogenicity of the apical area. There is just hypokinesia, global hypokinesia, but as it is reversible cause, there is no thinning, no echogenic structure as we find during aneurysm, apical aneurysm. So, and there is definitely for an apical aneurysm patient, there is a severe chest pain, history of severe chest pain. That Takotsubo patient also have severe chest pain, ECG changed and troponin, but the severity of Takotsubo cardiomyopathy may not be such severe for acute myocardial infarction, and they present usually with heart failure, not the acute coronary syndrome. Sir, I have some comments. Professor Tuhin madam rightly pointed out everything, but I want to add that there is some other secondary cardiomyopathy sometimes we misdiagnose is the PDA. The large PDA patient with reversible shunt, the murmur is not audible, but the LV is dilated, and there is some global hypokinesia, which sometimes misdiagnosed as the dilated cardiomyopathy. And another thing is that speckle appearance is not specific for hypertrophic cardiomyopathy. Speckled appearance may present in amyloidosis also. So this is not characteristics of dilated hypertrophic cardiomyopathy. And the apical sparing of in longitudinal strain, there is a good good nomenclature. The cherry on top is a characteristic of amyloidosis because a longitudinal strain escaped the apical area. So there is a red area of speckle, longitudinal strain speckle, and it is known as cherry on top appearance. Thank you, madam. Thank you for your excellent presentation.
Thank you, Momin. I have lost my connection, so I could not continue. Just when I got my connection back, I saw that you were talking, so I could not complete my comment. And you know that to cover all form of cardiomyopathy within a short time, so I could not give the all the points, and I cannot discuss all form of secondary cardiomyopathy in this short time.
I want to comment something.
Thank you.
Actually, what is presented here, it is a typical form of each cardiomyopathy. So if you search for typical appearance of hypertrophic cardiomyopathy and the amyloid cardiomyopathy, it's a grossly different. HCM, genetic basis, and speckle, that is different from amyloidosis. It's true. Another thing, I have did one echo of cardiomyopathy, and I did mistake ischemic heart disease with apical aneurysm. The apical segments was thinned out that time, and it looks like balloon. And that patient was done an angiogram in the later one, and found that coronary angiogram was normal. So retrograde analysis was that, clinical diagnosis was that, patient clinical diagnosis was that the recent cardiomyopathy. Okay. Actually, for the fellows, yeah.
I think the three most important differentiating factors is, one is reversibility, number two is thinning, and number three is echogenicity by echocardiography. But certainly the reversibility is the most important factor for differentiating between the presence of Takotsubo cardiomyopathy and apical aneurysm of LV. Also, the apical aneurysm is more localized, but the ballooning of the Takotsubo cardiomyopathy, when it is in the usual form, is more global. Thank you. Next question is, how can you differentiate between the hypertrophy of long-standing hypertension and hypertrophic cardiomyopathy? Tuhin, madam.
Okay. Long-standing hypertension usually gives the concentric hypertrophy, and it's difficult to differentiate, but according to the ASC, AHA, and ESC, the hypertrophic cardiomyopathy wall thickness must be more than 50 millimeter. And also strain parameter reduced in both cases, but when there is asymmetric hypertrophy, the strain is reduced more in the thickest segment. So presence of history and is very important in case of to differentiate the hypertrophic cardiomyopathy and long-standing hypertension. The degree of hypertrophy and the intercellular, the intramyocardial fibrosis and desire, that is a speckle appearance, though not definitive, but suggests the presence of HCM rather than long-standing hypertension.
Cardiac MRI may be a role here, madam.
Yes, yes. আমি একটু বলবো কার্ডিয়াক এমআরআই সেক্ষেত্রে যথেষ্ট রোল আছে বোথ ডায়াগনোসিস এন্ড প্রগনোসিসের ক্ষেত্রে। আমরা জানি যে সাধারণত 15 মিলিমিটারের উপরে গেলে আমরা চিন্তা করব যে এটা এসসিএম, which is not explained by physiological phenomena like pressure hyperload, systemic hypertension or aortic stenosis. In that case, we can consider ACM. If we think that there might be a uncontrolled severe systemic hypertension, in that case, we can do cardiac MR, which can show there is a fibrosis. We can detect by LGE, this is a sequence for MRI, you can detect fibrosis. And this fibrosis, not only for the diagnosis, it also help in the indication for ICD also. If the fibrosis amount is more than 15%, the chance of sudden cardiac death 5 times than the normal patient. So cardiac MR, there is tremendous role for the diagnosis as well as prognosis and taking the decision for the ICD also. Thank you.
By definition,
yes, thank you.
Is the absence of hypertension.
And aortic
by definition,
in the absence of hypertension.
And cardiac MRI is always more sensitive and tissue specific. So, but we are discussing about echo. Yeah. So, yes, ARVC and many tissue specific, we require cardiac MRI.
Madam, some doctors had wanted to know that how can you differentiate between constrictive pericarditis and restrictive cardiomyopathy by studying the inflow pattern respiratory variation by spectral Doppler?
Okay. Restrictive, the difference between restrictive cardiomyopathy and constrictive pericarditis is discussed yesterday also. Firoz has mentioned about the points. So only by seeing the respiratory variation, the martyred inflow, there is excessive respiratory variation in case of the constrictive pericarditis. But in case of restrictive cardiomyopathy, there is no respiratory variation, and IVRT remain constant in case of the restrictive cardiomyopathy. So by seeing only the respiratory variation, this is the martyred inflow, and to see the IVC, the dilated IVC with lack of respiratory variation is indicative of constrictive pericarditis.
Is there any cutoff point regarding the normal and abnormal for the respiratory variation of tricuspid and mitral valve?
Sorry, I'm not clear about this cutoff point. I have to go through the literature to see it.
There is normally some degree of respiratory variation for tricuspid and mitral valve.
25% and
25%. 25% if it exceeds 25% in case of
constrictive pericarditis.
Mitral valve, and if more than 40% for tricuspid valve, this is abnormal. So to some extent, respiratory variation may be normal. Next question is
constrictive pericarditis is easy.
We can use pulse wave Doppler for localization of the flow obstruction at the level of LVOT, and continuous wave Doppler for aortic stenosis. What is the explanation?
Pulse wave Doppler is a point specific. So it is whenever we place the sample volume at a definite point, even in case of the obstructive cardiomyopathy, by placing the pulse wave of Doppler from top to down, when there is point of obstruction, so it indicates the specific point when the velocity and gradient is increased. And continuous wave Doppler, measures the velocity along the line, throughout the line. It sums up the RPC and measures the peak velocity and the mid gradient. So for measurement, the peak continuous wave Doppler is recommended. And the basic difference, you have already explained in your basic Doppler lecture, the basic difference of pulse wave and continuous wave Doppler. The pulse wave Doppler, there is a single crystal which transmit and receive. So it can only indicate that where the velocity increase, but when it exceeds the Nyquist limit, and when there is increased velocity, it cannot measure. It can indicate the point of maximum velocity, but to measure it along the whole line, continuous wave Doppler is needed.
So it is the basic concept of Doppler. Because of the lack of localization value in case of continuous wave Doppler, you can just pick up any site of obstruction in the line. So it cannot differentiate between LVOT obstruction and aortic stenosis obstruction. But whenever you are going to localize the site of obstruction, you have to use pulse wave Doppler. And for this reason, as the level of obstruction in case of obstructive hypertrophic cardiomyopathy, this is the LVOT, not the aortic valve level. So we have to use the pulse wave Doppler essentially. Some want to know.
একটা কমেন্ট ছিল মনে হয় একটা কমেন্ট ছিল মানে ম্যাডাম খুব সুন্দরভাবে বলছে কিভাবে আমরা এমআর এবং এলভিওটি গ্রেডিয়েন্ট কে ডিফারেন্সিয়েট করতে পারবো শেপ অফ দ্য Doppler spectrum. One thing is that the LVOT gradient must not be suprasystemic. কখনো সিস্টেমিক ব্লাড প্রেসারের বেশি সিস্টোলিক ব্লাড প্রেসারের বেশি হতে পারবে না। ফলে আমরা যদি কখনো এমআরটাকে ভুল করে ওইটাকে ভেলোসিটি কাউন্ট করে দেখা যাবে এটা 200 150 160 হয়ে যাচ্ছে, সেক্ষেত্রে কখনোই এটা পসিবল না। ওয়াশিংটন ম্যানুয়ালের ছোট বইটাতে একটা ইকুয়েশন দেওয়া আছে, হাউ উই ক্যান ক্যালকুলেট দ্য LVOT gradient even from the MRJ and LVOT, VTI and other things. We can also calculate what might be the LVOT gradient, maximum LVOT gradient. So one thing we should know that it must not be suprasystemic.
Yes, yes, this is very important. Another question is, how long after acute myocardial infarction we can diagnose as ischemic cardiomyopathy if present? Is there any time demarcation for the diagnosis of ischemic cardiomyopathy after acute MI?
Usually acute MI is considered up to 7 days, and after 7 days to 1 month or up to 3 months, this is the recent MI. So after 3 months, it is chronic, and ischemic cardiomyopathy is a chronic condition. So at least 3 months have to be passed.
I think there is no hard and fast demarcation, but usually we have to wait for a certain period of time, that may be 6 weeks or more, for the definition of ischemic cardiomyopathy.
Monor bhai, আমি একটু কমেন্ট করতে পারি?
Sure.
Actually, myocardial dysfunction due to ischemia is ischemic cardiomyopathy, whether it is ACS or not. Even in chronic ischemia, chronic stable angina, patient may present with regional hypokinesia. It is already found. And if you revascularize the culprit artery, the regional wall motion will improve. So myocardial dysfunction due to ischemia, whether it is acute or chronic, this is ischemic cardiomyopathy. It's a practical definition. In
no. I do not agree with you. Yeah, there is myocardial ischemia in case of acute MI, but this is not ischemic cardiomyopathy.
Yes.
For the definition of ischemic cardiomyopathy, there should be some sort of negative remodeling.
Yes.
So, okay, in chronic stable angina, hibernating myocardium, the myocardium is hypocontractile. In that sense, when you define there is a obstructive coronary artery disease and LV dilatation, ejection fraction reduced, how we can, what do you level this status, this muscle appearance or function?
Say that a patient has presented with acute extensive myocardial infarction, anterior myocardial infarction, and just after 2 days, 3 days, we cannot say that he or she is having ischemic cardiomyopathy.
There is a lot of controversy.
Actually, okay, can I add one point? Actually, coronary artery lesion, that is LV myocardial contraction disproportionate to the coronary artery lesion. That is the ischemic cardiomyopathy. A known case of ischemic heart disease, but there are some territory of the coronary arteries that have insignificant stenosis but showing the hypokinesia. That is the
exactly. Cardiomyopathy basic জিনিস হচ্ছে যে আন্ডারলাইং কোনো কজ দিয়ে যদি এটা এক্সপ্লেইন না করা যায়, যেমন আমরা টার্ম ইউজ করি যে ভালভুলার কার্ডিওমায়োপ্যাথি, ভালভুলার হার্ট ডিজিজ দিয়ে এটা এক্সপ্লেইন করা যাচ্ছে না, এত বেশি ইনজেকশন ফ্র্যাকশন কমে গিয়েছে, দ্যাটস ওয়াই আমরা এটা ভালভুলার কার্ডিওমায়োপ্যাথি বলি। একই রকম ভাবে ইসকেমিক হার্ট ডিজিজে এমআই অথবা লেভেল অফ করোনারি আর্টারি অবস্ট্রাকশন দিয়ে যদি আমি এটা এক্সপ্লেইন না করতে পারি, দেন ইট ইজ ইসকেমিক কার্ডিওমায়োপ্যাথি।
এটা তো ডেফিনিশনে বলা আছে যে আনএক্সপ্লেইনড এলভি ডিসফাংশন, না আনএক্সপ্লেইনড এলভি সিস্টেমিক ডিসফাংশন।
ক্রনিক ইসকেমিক হার্ট ডিজিজ যদি থাকে, সাথে এলভি ডিসফাংশন থাকতে পারে, যেহেতু আদার ট্রিপল ভেসেল ডিজিজ আছে, সেক্ষেত্রে এলভি ডিসফাংশন থাকতে পারে, সেটা কি ইসকেমিক কার্ডিওমায়োপ্যাথি বলা যাবে না।